Okay, class, we are going to pick up where we left off this afternoon. We have talked about APGAR scoring in the previous chapter, so we're not going to revisit that because I know that you guys are familiar with what that is assessing for. Let's look at vital signs specifically, and if you want to look on page 860, you can review those. Typically, an infant will breathe 30 to 60 times per minute, and they do tend to have periods of apnea. Those should be very brief, less than at least 15 to 30 seconds is too much. At that point, we hopefully have already intervened at that point, but they do have brief periods of apnea in which if they continue, we need to look to see what else is going on. It could be infection, it could be several different things, but just know that they do have brief periods of apnea. The pulse rate, we've looked at this heart rate, 120 to 160 beats per minute. You guys know and understand that one. Blood pressure can be anywhere from 60 to 80 over 40 to 50. When we do a measurement, it's important that we measure blood pressure while the infant is sleeping or quiet. We don't want to try and assess a blood pressure when you have an infant who's screaming and crying or in distress. And we also want to make sure that we do a 4-point blood pressure when this infant is first born, because we want to make sure that there are no congenital heart defects, such as coarctation of the heart. If there's a huge significant change in right limb to left lower limbs, any changes in the upper and lower, we want to investigate further for some type of coarctation of the heart or another heart disease. Axillary temperatures, 97.6 to 98.6 is accurate for an infant. Remember, we don't bathe those infants until temperature is completely stabilized after about 8 hours. Cold stress does affect the infant and other vital signs, so we want to make sure that we keep them dry. We want to keep them out of breezeways, dress them appropriately, all of those things that we do for temperature. Skin to skin contact if they are cold, and then also remembering that cold stress can also affect blood sugar, so we want to make sure that we keep that temperature in those ranges as best we can. So those are your normal vital sign findings in an infant. So if you all have any questions about those, please let me know via email, and we will discuss them further. This is the APGAR screen. We've talked about that. I'm not going to review that again. You're probably not going to see this on the next test, so I know that you've already covered that and understand that. So let's talk about the appearance of a newborn. I'm going to be flipping back and forth with some of the photos. You do need to be familiar with some of these. You'll look on page 861 in box 2813, and you'll see some of these are described. Mila, of course, is the little tiny white spots. Sometimes people call it baby acne, but those typically are on the nose and chin, and those will eventually go away. It's really just, again, you'll see the occlusion of a sebaceous gland. A newborn rash, you may see what some people call little red spots. They may call them stork bites. If they're the flat pink or red marks, usually on the eyelids, nose, or sometimes on the back of the neck, you'll see those. Or they may call them, they may not know the difference between stork bites and the hemangiomas or strawberries. The hemangiomas sometimes tend to have a raised area, and they may call them strawberry birthmarks. Mongolian spots is just a darkened area, typically on the lower buttocks area or the lumbar spine. These are typically seen with, I'm not really sure, I'm trying to describe, people who tend to have darker skin. Maybe Asians sometimes may have them, or, if you're a Latino mix or something of that nature, you can tend to see those spots on the back side. The vernix is that cheesy substance that is what you see when an infant is first delivered. It sticks really, really good to the skin. That's why you see us almost scrubbing that off the skin. But that is a protectant for that infant from all that amniotic fluid floating around in there. Lanugo, you'll see in the next slide here, this tiny little fine hair here is what we call lanugo. And typically that will slough off after a couple of months, but that's your lanugo. And then the mottling, which is a marbled appearance, is here on the left in this slide. And this can sometimes happen with cold stress or temperature instabilities, or even infection sometimes will cause mottling in newborns. Jaundice, you guys know what that is. It's the yellowing discoloration of skin and eyes. Typically, something has happened with the liver. And so you guys know how to assess for that. In an infant, a lot of times you may see if they have a higher bilirubin level, you will see them using what we call bili lights, which is the blue lights, which help them break down the bilirubin in order to be excreted. Readiness, I have a photo for you guys to look at on in comparison for this one. You will see it's not a very good photo, but you can see the readiness of this infant here where the mouse is versus a typical infant here. And a lot of times the readiness happens when you have a traumatic delivery or lots of bruising. Basically, it's just the breakdown of those the excess red blood cells in an infant. So know what those readiness babies look like. It's just that red look in comparison to your normal newborn here on the right. Harlequin Sun is another one. The Harlequin Sun is very this one is very evident in children. You can see it has a clear line straight down the center of this infant, most noticeably on the face. If you are feeding an infant, sometimes they tend to think that it happens because of a change in positioning and blood flow. This is not harmful to the infant, and it typically goes away in just a few minutes. But if your parents see this, if you still have your infant in the facility, it can be alarming to them. So we want to make sure that we can educate them on what that is actually. And again, it's not harmful to them at all. It's just a shift in position, and basically blood flow catches up to it and then it disappears. The next one that you will see, I think that's all of the photos. Those are just some of the things that you would see in a normal newborn. As far as the face, we want to make sure it's well-rounded, no pitting areas, no cleft palates. That's important because cleft palates can affect their feeding abilities. So we have to be careful with that. In the next slide, you will see Epstein pearls, which is what we sometimes call baby teeth, but this is very rare, but it can happen. Typically, they will fall out within a week or so. If not, then they may actually go in and pull them because we do not want that to dislodge and our infants swallow them. The next thing is thrush. Many of you have probably seen this, or if you have small children, have experienced this. This is the white thickness that you will see in the mouth. And some of you who were in labor and delivery recently got to see some of this. We treat this with nystatin. Again, it is a candida infection in the mouth, and this can also cause some feeding issues. It's painful for some children, so we just want to make sure that we identify and treat it appropriately. Next, we want to look at their eyes. We want to make sure that they're symmetrical for the most part. They are edematous in the beginning. They're nearsighted. Again, a lot of this can be based on prematurity. Some infants who were born before about 24 weeks or 28 weeks, their eyelids are fused. So you may not even be able to really assess the eyes. Of course, all infants are born with pretty much the same color. And so just making sure that We educate parents on the administration of erythromycin. When infants are born, they're exposed to several different things, or could be exposed to several different things in the vaginal canal. So we want to make sure that we administer that erythromycin to make sure that we head off any infection prior to. Nearsighted, their best vision is between 8 to 10 inches. So when mom's talking to infant, we want to make sure that they're, within a foot of infant to get the best response. Strabismus is crossed eyes, or nystagmus, which is a shaky, jerky movement. And we have to remember that their muscles and everything, their nervous system is not completely or not as mature as everyone would be, depending on gestational age. So we have to look at that. So we have to make sure that parents know that strabismus is not uncommon. It's perfectly harmless. Now, if you continue into years of cross eyes or a lazy eye, as you may have heard it referred to, then we would have to do some interventions. Erythromycin, you are going to administer that. It's important to know how to administer that. Typically it is like a gel, and we put that in the inner canthus, and then we move across into the conjunctival sac. And we do this within 1 hour of delivery. Okay, so make sure you know what the medication is and how to administer that. The ears, we want to make sure, of course, that they're evenly placed when we look at the infant face forward. We want to make sure that we assess the ears and whether they are low set, if they have any skin tags on them. Those can be indicative of Down syndrome or some renal anomalies. We talked a little bit about the renal anomalies previously. So if they have a skin tag, remember, some things in a fetus develop at the same time. So we're going to make sure that if they do have skin tags, we look at the kidneys on ultrasound. Low set ears can be indicative of Down's syndrome, and we have talked about Down syndrome before. And low set ears and a semi-increase is a pretty good indication of a Down syndrome diagnosis. The umbilical cord, we've talked about that previously. 2 arteries, 1 vein. It can signify abnormalities if only one is present. That is not 100%, but that can be the case. So remember, 2 arteries and 1 vein. We always want to educate mom on umbilical cord care, clean with soap and water. I know that sometimes ATI uses alcohol, but for our testing purposes, we're going to do soap and water, keep it clean and dry. The most important thing with an umbilical cord is to make sure that you do not submerge that infant in water until it completely falls off, okay? It's going to dry, and that's okay, but we don't want it to dry and then submerge them back into the water and it gets wet again, just to prevent any instances of rebleeding. So again, do not submerge that infant until it completely falls off. And that's usually by about 10 days. With this cord still in place, it can be irritating if we put the diaper over top of it. So you want to fold the diaper down just below the cord to avoid any irritation or, again, causing that to rebleed, okay? A lot of times in a facility, you will see the cord clamp that you can see on page 863. They will clamp the cord, and with about 24 hours, they take that back off, especially prior to discharge. We want to make sure we take that off. When we talk about infant genitals, you can look on page 862 and kind of follow along. You'll see the picture in the middle of the page. They're very edematous at delivery, and this is just from the hormone exposure in utero. So you'll see that enlarged scrotum, and then you may even see some discharge from a female infant. There are several different things that can be emergent, like testicular torsion. If you assess an infant and they have purplish blue testicular sac, or however you want to refer to it, they basically have to go in and do surgery for that. That's not something you guys have to be extremely aware of, but just a couple things that you might see: hydrocele or testicles that are not descended. And again, if those things do not drop by about 18 months, they may require surgery. And we talked about this early on. Your cryptorchidism, which is not descended, and gynecomastia, which is an enlarged breast tissue in male newborns, but you may also see some enlarged breast tissue in the female, just because they were exposed to it in utero. When you're inspecting the genitals of a newborn, you want to make sure that you're inspecting a penis for the position of the urethral meatus, okay, or in simpler terms, the pee hole, okay? If it's malpositioned, then they cannot be circumcised, okay? If it's not dead center, if it's underneath, they can't be circumcised because they may need to do some other repairs or work based on, is it just malpositioned or is it affecting urine output? So based on a physician diagnosis, they cannot be circumcised immediately prior to discharge. So again, inspecting that. As far as their spine, we do look at that to make sure that it is straight without any curves. Again, we always want to make sure that we are inspecting for any signs of spina bifida. At the very end of the spine, sometimes they may have dimples or tufts of hair, and we call that a pit. And if that's present, it could indicate some abnormality of the spinal cord. So we want to make sure we assess for those. As far as their extremities, arms and hands are generally flexed against the body. This allows them to maintain some of that temperature and decrease some of the movements in maintaining a lot less use of glucose, basically, until they can transition well enough to maintain their own blood glucose after delivery. So when we swaddle them, we want to swaddle with their arms flexed against them, not just hanging out and about, just to reserve that blood sugar, that blood glucose. Hopefully the legs are the same length and the hips move freely. A lot of times you will see a physician do a hip assessment looking for that hip click. And if that's the case, they may have some hip dysplasia that could have occurred during delivery. So again, assessing hands and feet. When we talk about hands and feet, we have to talk about syndactyly and polydactyly. And then also amniotic band syndrome, which you guys will see in the next slide. We'll talk about that. So polydactyly, again, poly just means many. So here's an infant, if you'll see on your right, who has polydactyly, and this is actually a jointed extra finger. Whereas on the left slide, you will see polydactyly also, but this is more like a skin tag, and these sometimes are removed. The jointed extra finger is not removed. So that's your polydactyly. You guys will see this again. You have to know what that means if you see it on a test. The next one is polydactyly of the toes, and you can see there's two of several of their toes. Some may just have, again, either the jointed toes or just more so a toe that's like a skin tag that can be removed. So polydactyly, that's just more than one digits, or an extra digits, I should say. The next one is going to be syndactyly, and this one, if you look closely, you have to look really close to see it because these pictures are not the greatest, but this is just a joining here of the skin in the fingers. This can be in the hands or the feet. I think I have a picture. No, I don't. Syndactyly, anyway, is they're fused together, and those can be surgically separated, but you can see here where they're attached together. Okay. Now, amniotic band syndrome is basically an amniotic band wraps around the forming hand or foot or leg, and it basically inhibits the continued growth of that limb wherever that amniotic band might have taken hold. It can affect whether they have a full arm, half a hand, no fingers. And this is not widely common, but I have seen it in the past where children are fingerless or they have no hand at all. It's been wrapped around the wrist. So just kind of know what amniotic band syndrome is. I think I covered most of that slide. Yeah, amniotic bands. And then the simian line or simian creases. I think I have one next for that. So the simian crease, when we talk about Down syndrome, this is sort of hard to see, but you can see it really well in the picture. Normally you would have 2 creases here, but in Down syndrome, they're more likely to have a single crease here. And that is significant with other assessments in determining Down syndrome. So simian crease, you have to know what that is. You will see that again, I promise. And what it's indicative of. Jaundice, you guys know what jaundice is. You know what to assess for. Just that hyperbilirubinemia. It's going to cause yellowing of the skin and eyes. And then again, you saw the infant who was red and ruddy in a previous slide. Sometimes the infants who've had a traumatic delivery and they have that deep red pigmented skin from that, it sometimes is overwhelming to the liver and the body to process that. And so that's when they become jaundice. It's just basically preventing the breakdown of those used red blood cells. I think I have, yes. In this slide, you will see physiologic versus pathologic jaundice. You guys will have to differentiate between the two. And physiologic jaundice is just a natural increase level. Typically goes away in 7 to 10 days. And this typically happens after about 48 hours after delivery. And that's okay, that's normal. We're typically not too concerned with that. They may have an increase and then you'll start to see that bilirubin level decrease slowly. Now, pathological jaundice can be something of concern. It's usually present within 24 hours or less. So polycythemia, again, that leads back to that red ruddiness, just an excessive presence of those used red blood cells, and it does typically happen because of bruising during delivery. It can also happen with the RHO and ABO incompatibilities, and again, that goes back to blood typing with mom and baby, and they will do some bilirubin testing to see whether it is the RHO incompatibility or is it from a traumatic delivery. So know which one appears at 24 hours or less and which one appears at 48 hours. Now there's also the RHO and the ABO is called hemolytic jaundice. And again, that is leading you back to the Rh factor or the rhesus disease that we talked about previously. And that is again just the mixing of that blood with mom. So you can see the huge importance of ROCAM, not only in our infants. So not only do we have, just natural jaundice, but these other things can cause jaundice also. Breast milk jaundice is one that appears usually after about a week of feedings. If they're exclusively breastfeeding, it usually goes away. They don't typically require phototherapy like the other infants. But phototherapy, again, just helps break down that bilirubin and convert that into a form that's excreted typically in the urine. So jaundice, bilirubin. Yes, this is what I want to talk to you about. Kernicterus is basically jaundice that has been left untreated. And so what happens is those deposits can build up in the brain and cause mental deficits in your patients. Cerebral palsy it can cause, and it can also cause deafness if left untreated. That's why it's extremely important to monitor those ABO incompatibilities and whether jaundice is present at delivery or less than 24 hours, or is it breast milk jaundice and it's going to go away. So those are the important factors to consider with jaundice. So the head, of course, we all have talked about molding, so it's not always perfectly round, but we did talk briefly about how the sutures are not fused together, and this can be a good indication of dehydration. If you can palpate overlapping bones right at the suture line, they may be dehydrated. You can also see bleeding, and we'll talk about some of those in just a minute. Whether it's a caput or a cephalohematoma, which occurs typically during delivery. And a lot of this happens when there's a use of assisted devices in delivery. We talked about molding. So when we are assessing the head, again, the sutures should not be fused. Okay, so if you have an infant that you're assessing and it feels as though they're fused, have someone else assess that with you, because it has happened in the past. It's rare, but it can happen. And that can lead to other issues because there's no area for that brain to grow. So they may have to do an intervention for that. So a caput succeedum is just a fluid filled area that can cross the suture line. And you guys can see here, this one does, see where she has her little finger imprinted. It's basically just that edema from delivery or a vacuum assisted delivery. So that's going to be your fluid filled areas. And if you look here, a caput, this is not a great picture, but it does cross the suture line. And the importance of that is knowing which one does and which one does not cross the suture line. A cephalohematoma is just that accumulation of blood in the spaces between the scalp and the skull. This one does not cross a suture line. Okay, now those sutures close. The suture lines in an infant's skull fuse at about 18 months. You'll see here 2 cephalahematomas. This could be a vacuum assisted delivery or it could be forceps. You can't really determine, but it kind of looks like a vacuum. I don't know, but you can see it does not cross the suture line. Here's your suture line. And so we know that hema means blood. So that's a blood-filled area. And you'll see here the differences. So this is your cephalohematoma here, okay? It's not crossing the suture line, whereas the caput, it can cross the suture line. And again, that's your fluid-filled areas. So this happens more often with assisted deliveries if they're using some sort of assisted device. So know which one crosses the suture line and which one does not, okay? Metabolic issues. We've talked about admission of medications to infants at delivery, excuse me. So vitamin K is one of the medications that we give to an infant immediately at delivery. Parents can refuse this medication. So that's where we come into play as far as education. Remember, infants have an immature liver, and it takes a little while for them to catch up with their clotting factor production. And you'll see I have that here. So we're going to give them some vitamin K to help decrease that risk for hemorrhage after delivery. Now, I know you guys know your anatomy. You want to make sure that you know which muscle we give it in. Well, the vastus lateralis is one of the larger muscles that have been are used. It's the most well-formed muscle in an infant. So that's the site we're going to use, okay? So we give vitamin K to decrease the incidences of hemorrhagic events in the newborn, okay? So it may not say risk for hemorrhage, but if you hear someone talking about decreasing their risk of hemorrhage or hemorrhagic events in the newborn, this is what we're giving to prevent that, is that vitamin K, because our liver is not working correctly, nor is our colon. Okay, remember, we don't have any flora in that colon to synthesize anything for some time. So know why we give vitamin K and where we give it. Infant labs include glucose, white blood cells, hemoglobin, and hematocrit. The biggest one for you guys to know is your glucose. You guys will probably check as a nurse, of course, not as a student, they won't let you, but checking this glucose is often in a newborn, hourly. Some of them even. And then just some of your other lab values. You may already recognize those, but your glucose is the most important here. We talked about SIDS recently in class, and we talked about an exposure to smoke. Prematurity will increase their risk for SIDS. Sleeping in a prone position, meaning they're sleeping with their face down. If you think about an infant, their neck is not always as I guess the muscle is not as formed or as able to lift up that head as a 6 or 7, 8 month old would be. So you want to prevent that prone positioning because some of them are not able to lift their head. Bed sharing, we talked about this when we were talking about breastfeeding, and that we don't want to, have a mom breastfeeding and roll over on her infant or cover its face with that excess tissue, because they are obligatory nose breathers. Okay, we want to prevent overheating because that too can increase their risk of SIDS. And again, that is no extra blankets. Typically just dress them for the same weather that you are dressed for, and maybe one blanket in the bed. And speaking of beds, we don't want anything extra in the bed. We want to prevent that cluttered crib area. So back is best. Okay, educate every family member or caretaker that infants should be placed on their back. Okay. Now, if they're awake and alert, some tummy time is not going to hurt them, but you want to make sure that someone is supervising that tummy time, especially in the early months of newborn, because again, their muscles aren't fully developed and they can't lift their head necessarily. So risk factors for SIDS there. This is just some newborn data that I threw in there for you guys to look at if you want to. Some of you like the little Picmonics and some of you don't. That's okay. We've talked about most of this, but newborn screening, some of you may have gotten to see a PKU screening in labor and delivery. And so what they're looking for with a PKU is an absence of that enzyme in the liver to convert protein. And so if they have PKU, they have a special diet, because without the ability to convert that protein and use it appropriately, it causes a buildup. And if, as my slide shows, if it is left undetected, it can again cause mental disabilities. So again, what happens is they're going to warm that heel, and then you see the picture I have here also. You don't ever want to poke an infant in this part of the heel. You want to click your I can't think of what they call them, lancet on the sides after warming it. And you'll see how meticulous those dots need to be. If it's wrong and you have to recollect it, we're really probably should be doing an incident report, but because we didn't do it appropriately. But if it's incorrect, if it's incorrectly collected, then we have to recollect that from the infant. If they've already discharged, then they'll be recollected at their initial visit with their physician. So know what a PKU is, know what we're looking for, and if left undetected, what it can cause. All of these screenings are prior to discharge, and the parents know the outcome of these prior to leaving the facility. Hearing screen, they will know positive test or negative. Do they hear or do they not? And if there is some type of result in the hearing screen that may lead them to think that there is some type of impairment, they will set up a second test or refer them to a specialist. But every single one of these are performed prior to discharge. We've talked about the critical congenital heart defect. A lot of times this is either coarctation or something else. Usually before discharge, you will know some of them because their oxygen saturations are going to fluctuate or continue to stay low, like in the 70s or high 70s. But we do this critical congenital heart defect because lots of children go home and die with an undetected defect. So again, all of these are performed at the facility prior to discharge, your parents should have information regarding those. Again, know how to take a blood sample. You're going to warm the heel, and you are going to use the lancet on the outside areas or the inside area, never on the heel, okay? Because that's pretty painful. Hygiene, we always want to talk about hygiene with parents, especially with little boys. We want to make sure that they're cleaning in the area here. We want to make sure that they're, if they're uncircumcised, that we teach them how to pull the skin up and clean. And then when we talked previously about circumcision, this is what I was talking about. If you have a normal opening here, this is where it should be. And you have a circumcision, it's fine. But if you have a hypospadias, this is when your abnormal, hole is for urination is below here. Okay, so you don't want to cut the skin off and do a circumcision, because that could really affect future, reconstruction. So we don't want to do any circumcisions if this is malpositioned, okay? When we talk about circumcision care, it's our job to assess for bleeding after we do a circumcision, and we want to make sure that we put sterile gauze or just gauze with some Vaseline or petroleum, whatever gauze that you have applied, just to keep it from sticking to the diaper and continually pulling that exudate off to, cause additional bleeding. And so you see here, I have the normal healing process is called exudate. It's going to be yellow. It's not anything that's infected or anything like that. That's the skin regrowth, and that is normal. That's the normal healing process. So you want to make sure you educate your mother so that they don't continue just scrubbing that off, because if they do, it's going to continue bleeding. Okay. Now, if you have one that is continually bleeding after a number of checks post circumcision, you need to notify your physician so that we can intervene. Because remember, if they refuse vitamin K and they have a circumcision, then they could potentially have some excessive bleeding. So monitor for bleeding. Fussiness and refusal to eat, a lot of times after circumcision, they do tend to be a little fussy. I can't say I blame them. But again, allowing that mom to feed or a pacifier, some of that non-nutritive sucking will sometimes help console them. And some facilities will either use sweeties or Tylenol. It really just depends on physician preference. So that is an option for them. We talked about stabilization of body temperature. Again, after bathing, they're waiting 8 hours after bathing to make sure that that temperature stabilizes and that they're better able to control that themselves. As far as bathing, a lot of times if you have an infant who was a drug addicted baby, we can do what we call a swaddle bath. PT would usually do this with them. It really just promotes comfort, just that warm water and a sense of security, basically. Of course, bathing allows for bonding time. A couple of big things that ATI really talks about is watching that water temperature. Okay, we don't want to put them in scalding hot water, so we want to make sure that the hot water heater itself is not above 120 degrees, and we want to make sure that, of course, our bath water is not, above 100. Okay. Another thing with bathing, I know in the old days they used to put baby powder on them because they smelled so nice and wonderful, but we absolutely do not put baby powder on any infant in the genital area. You've probably heard about the Johnson & Johnson lawsuit, and so that's probably where that began. So absolutely do not use baby powder, and we need to make sure that if we see a mom using it, that we intervene and educate her not to use that. Again, as far as bathing, it could affect their temperature. So if you're bathing an infant, you might want to make sure that you check a temperature prior to bathing to make sure that they're not on the borderline, because the last thing you want to do is create some cold stress for that infant. Okay. So bathing, if your mom has any questions, especially first time moms, we need to make sure that we know how to educate them. next is our infant reflexes. If you guys look on page 864 and 865, you'll see a lot of these photos here. A couple that I want to talk about that are not pictured here are rooting, sucking, their gag reflex, and swallowing. And so as nurses, if we're feeding them, we tend to see their rooting reflex, which is basically if you tap on the cheek, they're going to turn their mouth to either side where they feel that tapping because they're hungry. They're rooting so that they can, initiate a feeding or let you know that they are in fact interested in feeding. Sucking, of course, we've talked about clipping the tongue a lot of times because some can be impaired if it's really short and they're not able to suck well, or if they're premature or they don't have the muscles to suck, swallow, and breathe very well. So we want to assess that rooting reflex, their sucking reflex. If we give them a passy, do they suck on it or do they not know how? And then gag reflex, of course, we don't want to gag an infant, but a lot of times if they're nursing or taking a bottle, you can see if they take too much, they tend to gag. And do they swallow? Do they know how to suck, swallow, and breathe really well? If they don't have that much coordination, especially preterm infants, it can be very difficult for them. Now, the biggest thing is knowing which is the priority assessment. Do we worry about rooting? Not necessarily, because some infants will feed even if they're not interested. Sucking, just depends. I mean, we want to make sure that, first of all, they can swallow safely and that they do have a gag reflex, because if they don't have either of those, then we are setting ourselves up for either an infection of the lungs or aspiration. So making sure that we know what that priority assessment is, okay? We want to make sure that they're able to swallow and they have a gag reflex. If they don't have those, they shouldn't be rooting or sucking anyway. The Moro or the startle reflex, this is when you see that infant's hands go up in the air and they sort of just shake, okay? Tonic neck reflex, you guys can see this one. This one I don't see a whole lot, but when you flip the ends, when you turn the infant's head to one side, that arm and that leg extend on that side. It just kind of looks like they're in a fencing, or I don't know, it's awkward. You can see this one on table 28.5. You'll see that leg is extended and the other one is pulled closer to the body. I rarely ever see that one, but the dancing or the stepping reflex is when you hold the infant up, yet their feet are still on either a table or their bed. And when they touch, it almost looks as if they're walking or marching, because their feet tend to just up and down, extension and flexion, almost as if they're walking just by their feet touching that surface. This is one that you will see physicians checking often, and this one is a huge indicator in the nervous system. That is the Babinski reflex. A typical infant, when you see the picture and you'll see the arrow pointing from the heel, swiping all the way over to the toes, it's present in most children who are 1 year or less. And that's normal because they still have that immature nervous system. However, at a year or greater, if that is still present, then that can be an indicator of some type of central nervous system damage, whether it be during delivery or, maybe they fell and hit their head while they were an infant, something of that nature. So Babinski reflex is one of the most important ones outside of feeding reflexes that you need to be mindfully aware of, okay? It's a neurological indicator in whether it's intact or if there's some type of nervous system damage. So again, looking at that picture to make sure that if you see that dorsiflexion of that big toe, okay, that's your Babinski reflex, okay? And that's normal. But if it's still present in 1 year or greater, then it is an abnormal indicator. The grasp reflex is basically you are going to put your finger in the palm of their hands and they're going to grasp it. Okay, same thing with the feet. If you put your finger at the bottom of their foot, their toes are going to curl down toward your finger. Now, the pull to sit reflex, this is when you check head lag. And so if you have a regular newborn versus an infant who was drug exposed, then you will see the difference in the two. Because a normal newborn, you're going to have some type of head lag when you pull those little arms up. Whereas with an NAS infant or one who might be going through withdrawal symptoms, they're they're not going to have any head lag. They're so tight and tensed up that their whole head comes up with their body. So the difference in that is just basically it helps assess whether there's true NAS or just a immature system. Okay. Now, the head lag is going to be greater for those who are more premature, but a normal newborn should have some head lag, and an NAS infant will have zero head lag. So that's your pull to sit reflex. As far as bowel and bladder elimination, infants should have some type of elimination within 24 hours. If not, we need to inspect why. There has been an occasion where an infant has a meconium plug, and basically what happens is it becomes a blockage. That meconium stool becomes a blockage, and then we have to, either do some type of surgical intervention if it can't be passed, or sometimes with feedings, they can tend to pass those through. But just knowing that within 24 hours, if they do not have a wet or dirty diaper, then they're going to start to investigate why. Okay. When we talk about elimination, let's talk about hydration status and nutritional status. Breastfed infants tend to have more frequent stooling. It's usually pale yellow in color, and you'll see this on your book or in your book. Let me find the page for you. On page 870. So breastfed infants stool almost with every single diaper. It typically has a sweet smell, as crazy as that sounds. And it has like little curds in it, like cottage cheese almost. So with breastfed infants also, iron is best absorbed through breast milk. Formula and milk tend to have less iron in them, but breast milk typically is higher and easier to absorb. So know the difference between breastfed infants and formula fed infants in the fact that breastfeeding babies tend to have a diaper every single feeding, whereas formula fed infants only have 2 to 3 per day. Elimination, and when we look for bowel and bladder patterns, is a good indication as far as nutritional status and hydration status. Your ATI book will tell you 6 or more wet diapers per day is a pretty good indicator that they're well hydrated. As far as nutritional status, we can gauge whether they're getting an appropriate amount. Are we seeing some weight gain or not? Okay. Do we have some failure to thrive? Failure to thrive is typically when they're in like the 5th percentile or less. And at that point, we're going to really look to see why. Are they just not getting enough if they're being breastfed, or are they eating and then just maybe continuing to vomit, so they're not really digesting or absorbing any of it? So with failure to thrive, they're going to start looking at that if there's no weight gain. Fussy infants, sometimes it could be the formula. It's upsetting their stomach, depending on what formula they might be taking. They may need a more digestible form of infant formula versus breastfed infants. If they're sleepy when you're feeding them, we want to make sure that we hold them out away from us, not close to us where they're warm and snuggly and they go right back to sleep. So just making sure we teach mom to keep them out away from her, maybe in a sideline position for feedings. So know the difference between breastfed and infant fed or formula fed infants and how many stools they might have per day, and then our indicator for hydration status. Of course, maintenance of a clear airway is always critical. We establish that upon delivery and hope to maintain that from there on out. If not, we've talked about this. If suctioning is something that we need to do or is required, we suction mouth to nose, okay? I know this slide is backward, but it's from the mouth to the nose. Remember, we go with our ABC. So mouth first and then our nose. As I said, infants are nose breathers. So we have to make sure we keep those clean. Crying is their only means of communication. It can be, I just need some attention, or I'm hungry, I'm in pain. However, crying can also be a neurological indicator in any type of damage or an NAS infant. If you have an infant who is continually crying and they are non-consolable, either by mom's, touch or talking or being held, or if they're NAS and medication doesn't ever stop that high-pitched cry, that could be a good indicator that there's some type of central nervous system problem, whether it could be NAS, it could be shaken baby syndrome, it could be any number of things. As far as process of elimination, that's up to the physician as to what type of neurological damage there might be. But just that real high-pitched cry that's inconsolable is a good indicator. While we're talking about that, we've talked about parent bonding before, so we won't dive too much into that, but you will have to be familiar with some of the quieting techniques that are on page 871. Swaddling is a big thing. We always want to make sure that we swaddle them with their hands near their mouth, and not just down by their side, stiff as a board. This one talks about newborns need extra sucking to soothe them. Sometimes non-nutritive sucking with a pacifier really helps console infants. Babies love to be rocked in a rocking chair, and if mom's on board, maybe some skin to skin. Look at them, talk to them in a very soothing voice. And remember, you have to be within about, a foot of them so that they can kind of visualize. Remember, their eyes will only see about 10 inches in the beginning, okay? Changing positions. You can buy some wedges sometimes to, elevate them from side to side, but not placing them in a prone position unless they're awake for tummy time. This one also talks about a rhythmic, monotonous noise, like white noise or something of that nature. This one also talks about pre-warming the crib sheets with a hot water bottle, or putting the sheets in the dryer or something, but really just keeping the infant warm. Again, that might lead to some skin to skin. Just be familiar with some of those techniques as far as quieting them. And then if those don't work, again, that neurological high-pitched cry, that could indicate some central nervous system damage. This is everything that we have in an infant assessment. So if you guys will review this, and if you have questions, please send them to me. We are still on schedule to have our test on Monday. So if you have questions about it, please let me know. I am able to access my email, but please don't wait until Sunday to send an email to ask about questions. If you have them, please let me know prior to that.